Thank you. Thank you. So, as many of you would be aware, antimicrobials are often used to prevent and treat infections. But when they're used inappropriately, especially in older and frail populations, they can have negative consequences that include harmful drug interactions, side effects, and also infection with antimicrobial resistant organisms. In Australia, a residential aged care home is a type of long term care facility for older people who can no longer live independently in their own home. They can provide services that include personal, clinical, and social care around the clock, and also hotel like amenities. The demand for these types of homes in Australia is rising. There's currently about 2,600 residential aged care homes operated by over 700 approved providers, and they house almost 200,000 residents. The global rise in antimicrobial resistance poses a significant threat. It can lead to ineffective treatment of common infections. It could lead to increased risk and length of hospitalisation, also mortality and unnecessary healthcare costs. Antimicrobial stewardship, or AMS programs, incorporate a set of strategies aimed at optimising the treatment of infections while reducing adverse events associated with antimicrobial use. The implementation of these types of programs in long-term care facilities is widely recommended. And in Australia specifically, the national quality standards do require residential aged care homes to implement AMS programs that complies with contemporary evidence-based practice and is relevant to the service context. The implementation of AMS strategies in long-term care facilities can be challenging, and their impact on improving antimicrobial use has varied considerably. There are barriers to implementing AMS programs in long-term care facilities, and these include things like organisational culture, resources, and also availability of and access to knowledge and skills. A point prevalence survey is a type of study that collects information at a single point in time. So it gives you a snapshot look. And it's used to look at things like prevalence of a risk factor or a characteristic or a health outcome in a population. The repeated use of point prevalence surveys for monitoring healthcare associated infections and antimicrobial use in long-term care facilities is recommended by the Aged Care NAPS and also the HOLT project. So the annual aged care NAPS started in 2016 in Australia, and it's freely available for all Australian residential aged care homes. In the state of Victoria specifically, participation has been mandatory for all public residential aged care homes since 2018. So with this study, what we wanted to do was to look at whether repeated point prevalence surveys to monitor antimicrobial use have shown any changes in their prevalence over time. And we did this using two methods. So firstly, we looked at a fixed cohort of Australian residential aged care homes. And secondly, we used what I'll refer to as open cohorts, and these were various worldwide long-term care facility cohorts. And in a couple of slides, I'll explain a bit more about the difference between these two cohorts or types of cohorts. We also wanted to look at whether in the fixed cohort of Australian residential aged care homes, there's been a change over time in key AMS quality of care indicators. So the fixed cohort was made up of Victorian public residential aged care homes that participated in the aged care NAPS every year between 2018 and 2023. Any facility that had a change in ownership during this time were excluded from our analysis because new governance might have led to significant changes to the AMS program, and this wasn't investigated as part of our study. We also excluded data from 2016 and 2017 because this was before the requirement for all Victorian public residential aged care homes to participate in the aged care NAPS. For the open cohorts, we identified studies through a search of Medline, Embase, and CINA, and any study that described at least two standardised point prevalence surveys that were used to monitor antimicrobial use in long-term care facilities that were done between January 1991 and March 2023 were eligible to be included in our analysis. So now going back to that difference between the fixed cohort and the open cohort, essentially the key difference is that for the fixed cohort, each survey was made up of the same group of facilities that were followed over time. In the open cohort, some facilities might have participated only in some of the survey years and not others. So they don't necessarily form a continuous time series. Now, in the fixed cohort, we use Poisson regression essentially just to look at the number of residents that were prescribed antimicrobials over time to see whether there was any change or not. We also wanted to see whether this prevalence of antimicrobial use differed pre-COVID versus post-COVID pandemic. Many of our open cohorts were from the ESAC and HALT studies. So I already quickly mentioned the HALT project before. The ESAC project, or also known as the European Surveillance of Antimicrobial Consumption, was a multinational project that conducted point prevalence surveys in European long-term care facilities. And they did this twice. So first in April of 2009 and then again in November of that same year. The HALT project came after ESAC, and it's based on the ESAC project. And as of March 2023, which was the cutoff date for inclusion in our analysis, there had been 3 HALT reports that had been published, or 3 HALT studies that had been published. They were from 2010, 2013, and 2016. Now, for our analysis, we grouped point prevalence surveys by, For our analysis, point prevalence surveys were grouped into cohorts by country and by study. So what this means for ESAC and HALT, which were multinational projects, it means that each country was considered its own separate cohort. So for example, we had Belgium ESAC, we had Austrian HALT, and so on. Now, because as I mentioned before, these cohorts don't necessarily form continuous time series because some facilities participated sometimes and not other times, we couldn't do a time series analysis. So instead, what we did was we compared the first versus the last point prevalence survey, and essentially we had to ignore the surveys that occurred in between. There were 188 Victorian facilities, public facilities, that participated in the aged care NAPS between 2018 and 2023. And of these, 53 participated every year in that time period. The vast majority were from inner regional area, followed by outer regional, and only a small handful were from metropolitan Melbourne. Looking now at the percentage of residents or the prevalence of residents that were prescribed at least one antimicrobial in each of those survey years, we actually didn't see a change over time between 2018 to 2023 overall. When we then looked at pre-COVID versus post-COVID separately, we did see a significant decrease in the pre-COVID years, but noting that we only had a short time series pre-COVID, we only had 2018 and 2019. In the post-COVID years, from 2020 to 23, we actually saw no change over time in antimicrobial use or the prevalence of antimicrobial use. We also looked at the percentage of antimicrobials for which the indication for prescription was documented, which is that orange line that you see on the graph. And what we found was that there was a significant decrease between 2018 and 2023 of on average about 5% per year. We also looked at the percentage of antimicrobials for which the review or stop date was documented, and this didn't change over time. This was relatively stable in between those years. Now, for the open cohorts, we had 51 different cohorts from 30 countries that were included in our analysis. One was the aged care NAPS from Australia. There were 20 separate ESAC cohorts and 27 HALT cohorts from various European countries. There was one study out of the Netherlands that conducted annual surveys for a period of 11 years. And there's also one from Northern Ireland that conducted 2 surveys, but in 2010 and 2011. The time between the first and last point prevalence survey of the cohorts that we included ranged from 7 months, which would have been the ESAC studies, to 11 years, which was that Dutch study that I mentioned before. Now, When we compare the prevalence of antimicrobial use in the last versus the first point prevalence surveys, and the figure there doesn't show all 51 cohorts, what we found was that there was a decrease in prevalence of antimicrobial use in 6 out of the 51 cohorts, and there was an increase in 8 of the 51 cohorts. But this makes up only slightly more than a quarter of the cohorts, meaning that for the vast majority of the open cohorts, we actually saw no change in the prevalence of antimicrobial use over time. So across repeated point prevalence surveys, there was no major change in the proportion of residents receiving antimicrobials in Australia between 2018 and 2023. And the prevalence also remained stable in most of the international cohorts that we analysed. This persistently high antimicrobial use in Australian residential aged care homes aligns with findings from other national studies that have used pharmaceutical claims data or electronic health record data. And these studies had shown that either there was increasing use or inconsistent patterns over time. That we found a static prevalence in antimicrobial use could reflect limited opportunities for improvement because appropriate antimicrobial use has mostly been achieved. But determining appropriateness is challenging because of limitations in the current criteria that's used to assess appropriateness. So, for example, the McGee criteria, which is often used for assessing appropriateness of antimicrobial use in long-term care facilities, was actually initially designed for infection surveillance. And so it might not be adequate for real-time case finding or diagnosis or clinical decision-making, such as antibiotic initiation. There's also the LOAB criteria, which is meant to guide antibiotic initiation in residents, but it may not be consistently used by practitioners when making treatment decisions. AMS programs in Australian residential aged care homes need to be strengthened, and they also need to be regularly assessed to ensure that antimicrobial use is improved. The majority of these homes are now using electronic medication management systems, and to safeguard prescribing and administering documentation is completed, there could be an opportunity for incorporating relevant mandatory data fields into these systems. It's very important to note that point prevalence surveys are only one component of an AMS program, and it's likely that multi-component strategies that target all stakeholder groups are needed. Substantial funding has recently been made for on-site pharmacists to be embedded in Australian residential aged care homes, and also for eligible GPs and practices to receive incentive payments for providing regular visits and care planning for residential aged care homes. This is in addition to the requirement that all of these homes employ a trained infection prevention and control lead. Overall, a large number of long-term care facilities were included in our study, and this indicates that repeated point prevalence surveys are relatively easy to perform, and they can be useful to observe trends of antimicrobial use over time, especially in high and upper middle income settings. A key strength of our study was analysing data that was submitted by a fixed cohort of Australian residential aged care homes that participated in the aged care NAPs annually over 6 years. So this cohort now especially has a strong foundation for monitoring the AMS programs. We do need to be cautious when we compare across the open cohorts because of differences in surveillance methods, of the timing of data collection, of team expertise. We also expect that resident factors could have biased the estimated prevalence of antimicrobial use in both the fixed cohort and the open cohort. And this is because of possible changes to resident populations from year to year. What do I mean by resident factors? These can include, for example, the number of residents with dementia who may not be able to clearly describe infection signs and symptoms. It could also be advanced care plans that favour ongoing antimicrobial use and life prolongation. It could be a request for antimicrobial use from families. There's also resident hospitalizations for infection-related diagnoses, which can change over time. And this would impact the number of antimicrobials that are captured by a point prevalence survey, which again, remember, is a snapshot in time. In the open cohorts, specifically, non-resident factors could also have affected prevalence estimates. This is less likely to be a problem for the fixed cohort because the non-resident factors within the fixed cohort are likely to have remained relatively stable over time. And what do I mean by the non-resident factors? They can include, for example, diagnostic resource utilisation, which can contribute to diagnostic uncertainty. It could be physicians' perceived risks of treatment. It could be a request for antimicrobial use from nursing staff, and also environmental factors. So things like prescribing guidelines for older adults and also local antimicrobial resistance patterns. In summary, our study highlighted high antimicrobial use persists in long-term care facilities, and there's an ongoing need for the development and implementation of targeted, effective AMS strategies in this challenging setting. To inform long-term care facility AMS programs, it is our recommendation that future repeated point prevalence surveys are standardised, to also additionally judge appropriateness of antimicrobial use and identify determinants of inappropriate use. And also to ensure precise benchmarking, adjusting for different surveillance methodologies and study populations is essential. I'd like to end by thanking everyone that's contributed to this work. Thank you.
Thank you for the presentation, Stephanie. Really interesting results. We'll now take any questions for Stephanie. While we wait for the questions to come through, I did have a question for you, Stephanie. With your study findings, what's the next steps and what's the future direction?
It's a good question. I think digging deeper into why we haven't seen any change over time, because some of the time series, some of the study periods that we looked at were quite long, and to sort of see a stable prevalence globally, it seems like, is maybe concerning. But as I mentioned before, there is a lack of information about that appropriateness that we need to dig deeper into.
And I did have another question around inclusion of other states and territories. It looked like only Victorian aged care homes were recruited and participated in this study. Can we extrapolate this information and does that apply to other states in Australia? And why were homes from other states not included?
I don't think I know enough about what the other states do or what it's like to comment on whether they'd be very different, but I can answer why we excluded them. So because we had quite a strict criteria of they needed to have participated each year over a 6-year period, I think before we put on that restriction that they were only Victorian public facilities, we only had a small handful, I think less than 5, that ended up being from a different state or not a public facility. And so for a cleaner sort of cohort, we just put the restrictions on.
Great, thank you. We've got some questions in the questions and answers functionality. Question from Joanne: are there any countries doing well or better? And how does Australia compare to other countries?
Well, there was no country that stood out, at least in our analysis. But also, again, going back to the fact that it's quite hard to compare across countries because a lot of, especially with the ESAC and HOL studies, which made up a lot of our cohort, it was a voluntary sort of participation. So we don't really know who were captured, who volunteered. I think the long-term care facilities across countries would have been quite different. Survey methodologies might have been different, even though there was a study protocol everyone was supposed to follow. I think ultimately how it was conducted, when it was conducted, that still could have differed. And so when you're seeing when you're seeing a difference between countries, you don't really know if it's an actual difference between countries or simply a difference in methodology. It could be either. We don't have the answer for that.
Excellent. Another question from Fiona. Do you think the results are complicated by the pandemic, for example, higher use of antivirals?
That's a great question. So we did try to look at that. We tried restricting, at least with the aged care naps analysis, for the use of antivirals, and there was actually hardly any COVID-specific antivirals that were being used. So excluding them from our count didn't actually make a difference to our results. But also, the aged care naps was the only survey that sort of ran over the pandemic period. So we didn't see any, we don't have any data from any other cohorts.
And just a comment, I can't recall the study period, but COVID oral antivirals only became available a few years into the pandemic. And prior to that, there were a lot of aged care residents who were quite unwell with COVID that were being admitted into the hospital for IV treatment. And I don't think that would have contributed to the data in your study, Stephanie.
Yes, yeah, yeah. Great point.
And a question from Christian, are there any particular trends on the types of antimicrobials used?
No, well, look, I can't comment on that. I didn't see anything. I didn't pick up anything, but we didn't also dig in too deeply into the types of antimicrobials for this particular study. But that would be something interesting to look at.
A question from Caroline. Do these studies take into account clinical consequences of not administering antibiotics? For example, behaviors commonly change in the case of a urine infection. Urinary sepsis is often the outcome leading to fatality. If you want me to repeat that, I can do it. It's a pretty mouthful.
So the short answer is no, that was not something we specifically accounted for, not for our analysis.
Excellent. A question from Catherine. Do you think complications of COVID, for example, chest infection, may have contributed to increase in antimicrobial prescribing?
Um, That's not my area of expertise. It seems reasonable that it might have, but it wouldn't have been attributed to COVID specifically. So it would have just been picked up as an increase. Although in the COVID period, again, we didn't see, if we think back, I could show it again. The figure pretty much showed a flat line. It didn't spike during COVID, even without a significant spike. It was just flat. So unless something else dropped off and was replaced by the use of any antimicrobials in response to any COVID complications, then no.
Excellent. Thanks so much, Stephanie. We'll move on to the next presentation. Okay, next up we have Dr. Dipti Khatri. Today she'll be talking about exploring a role for antibiograms as an antimicrobial stewardship tool in residential aged care homes. Dipti is a credentialed medication review and aged care on-site pharmacist with a special interest in AMS. She has already completed her Master of Clinical Pharmacy degree in 2019, which included an AMS-focused research project. This led on to further PhD research on the topic of antibiograms in aged care. She has successfully published all the findings from her research projects, and she continues to raise awareness about antimicrobial resistance as well as AMS for staff and residents of aged care homes through education initiatives. Thank you, Dipti.
Thank you, Josephine. Can you see my slide? Yep, okay. So, good morning, everyone. Today I'll be presenting my PhD research on exploring a role for antibiograms in Australian residential aged care settings. I refer to them as RAFs from here on in. I would like to acknowledge my supervisors and advisors for their support. I'm currently working as an aged care on-site pharmacist. So I would also like to thank my employer, Choice Aged Care, for their continual support. So just following on from Steph's back. Apologies, my slides have stopped clicking forward. Give me a sec, sorry. Sorry, I'm not sure what's happening. Is it okay if I just stop share and just reshare again?
You have already stopped sharing. We'll just wait for you to reshare the slides.
Okay.
Let me know if you need me to do anything.
Yes, just give me 1 sec, please. My slides have just stopped working for me. Okay, back on track. So just a very brief background. So a recent systematic analysis of global data indicated that deaths associated with antimicrobial resistance increased by 80% for adults 70 years and older. And this statistic really highlights the importance of continued research in this space. We know that the prevalence of antimicrobial resistance is higher in RAFs, where antimicrobial use also remains higher than in community. Empirical prescribing is commencement of antibiotics prior to the receipt of microbiological investigation results. And this is reported to be common in RAFs, with a couple of studies suggesting that up to 60 to 80%, 85% of antibiotics may be prescribed in this way. Suboptimal empirical prescribing contributes to inappropriate antibiotic use and can lead to infection-related harm. Confirming the clinical criteria for infection and knowledge of resistance patterns can optimize empirical prescribing. This local resistance data can be provided with antibiograms. An antibiogram is a summary of antimicrobial susceptibility test results for specific microorganisms to a panel of antibiotics for a specific location and for a specific time period, which is usually 12 months. In this particular antibiogram example, if we look at the E. coli and amoxicillin pair, we can see that only 54.7% of the isolates tested were susceptible to amoxicillin, which indicates that E. coli from this location having high resistance to amoxicillin. Guidelines suggest that when possible, we select antibiotics with about 80 to 90% susceptibility. This particular example is from a hospital setting. So antibiograms may be used to inform treatment guidelines, promote use of narrow-spectrum antibiotics, and also provided surveillance of resistance patterns, which is called for as per national and global guidelines. In Australia, antibiograms are typically utilized in hospital settings. And with my research, we wanted to evaluate whether there is any role for antibiograms in Australian RAFs. We planned and conducted 4 studies to address this overarching aim. The first of which was a systematic review, which included 37 studies. And we found that AMS interventions that utilized antibiograms as an integral component may improve antibiotic consumption patterns, appropriateness, and possibly provide cost savings. Most of these studies were conducted in hospital settings. For our second study, semi-structured interviews were conducted with key stakeholders to understand the barriers and facilitators to the future development and use of antibiograms in RAFs. We interviewed 15 clinicians or end users and 5 antibiogram experts. Our key findings indicate that not much is known about the use and availability of antibiograms in RAFs. Challenges involving low isolate counts to develop RAF-specific antibiograms were identified, and suggestions were made that these challenges may be overcome with increasing the time period of data or by pooling nearby RAF data, which we explored with our third study. In terms of implementation of any future antibiograms, accompanying education and presentation of the antibiograms would be crucial. On-site AMS on-site AMS champions and pharmacists were considered essential for the adoption of this AMS tool. For our third study, we recruited 9 RAFs in South Queensland, 2 of which would be described as small, 1 as medium-sized, and the remaining 6 were considered large RAFs. The antibiograms were developed as per the guidance from CLSI M39 approved guidelines. A couple of the key recommendations were inclusion of pathogens with a minimum of 30 isolates and the use of first isolate only in that time period. All positive culture results were manually collected for all residents over a 3-year period from 2020 to 2022. The data was then sorted and entered into WhoNet software, which is a free Windows-based software developed for the management and analysis of microbiology lab data. And then the susceptibility summary data was extracted from WhoNet. So in terms of what we found, 70% of the positive cultures were from urine samples and 27% from skin and soft tissue. The most prevalent urinary isolate was E. coli, and the most prevalent skin and soft tissue isolate was S. aureus. So we explored the isolate counts of these 2 organisms to explore the feasibility of our antibiograms. As mentioned before, the minimum of 30 isolates is recommended for inclusion in antibiograms. So looking at the urine samples first, this graph shows that the number of E. coli isolates for each of the 9 RAFs in our study, if we look at the first 3 bars, this represents annual data. So first 3 bars of each set. So it's a dark blue, orange, and green bar. And the 4th light blue bar represents combined 2021 and 2022 data. And the last purple bar in each set represents the isolate counts when all 3 years of data was combined. The red dashed line represents that minimum recommended 30 isolates. So what we can see is that none of the 9 RAFs had enough isolate counts to develop annual antibiograms. And when the data was combined for 3 years, 7 of the 9 RAFs achieved data sufficiency for E. coli from urine samples. For the skin and soft tissue samples, again, we can see that no annual antibiograms were feasible. However, sufficient number of Staph aureus isolates were noted for 5 of the 9 RAFs when triennial data was considered, 3 years combined. So extending the time period of antibiogram to beyond the usual 12-month period could offer one potential solution to low isolate counts in this setting. The second option we explored was to increase isolate counts was to include pooled RAF data. So from our study, data was pooled for RAFs which were co-located within a 30-kilometer radius, as indicated by this purple circle. And so going back to our bar graphs, looking at the very last set of bar graphs, we can see that the annual antibiograms were feasible for E. coli from urine specimens for all 3 individual years when we pooled the data geographically. Similarly, we found the same for Staph aureus from skin and soft tissue isolates samples that annual antibiograms were feasible for the individual 3 years. So here is an example of the pooled data urinary antibiogram that results from our study. The color coding was adapted from the publicly available Sullivan and Nicolaides pathology antibiograms. We added the classification of the antibiotics as per the Australian priority antibacterial list. Note that only E. coli attained the recommended minimum isolate count. 71% of the E. coli isolates were sensitive to trimethoprim, which is one of the usual first-line recommended antibiotics for uncomplicated UTIs. Very minimal resistance to nitrofurantoin was noted. For the skin and soft tissue isolates, we only could include Staph aureus because we chose a minimum of total 10 isolates for inclusion in the antibiogram, and no other microorganisms could be included. The antibiograms can be hard to interpret for some end users. So the local resistance antibiogram data could be included in the diagnostic and treatment algorithm, as shown here with the purple arrow. This diagnostic and treatment algorithm was adapted from the therapeutic guidelines, and we have just added the antibiogram information into this algorithm to help assist the use of this local resistance data. So this was one of the proposed ways in which our information could be used. The task of producing these RAF antibiograms are time, labor, and cost intensive. It is possible that pathology data was missed, as not all data was automatically available for the RAF to view online. And for those RAFs not using online portals, not all pathology data may be uploaded to the resident's electronic record or stored in their physical files. Multiple pathology providers service the RAFs that were involved in this study. And so the provision of data directly from the providers would have been of benefit. And it would be of benefit going, in future for any RAF wanting to develop their own antibiograms. With these challenges in mind, we compared the antibiotic susceptibilities from our RAF antibiograms with other available resistance data, with the aim to determine whether the other data could be used to approximate resistance patterns in RAFs. So the pooled RAF antibiograms were compared with other available RAF resistance data sourced from publicly available statewide SNP antibiograms and MARA pathology data, which was sourced from Auctrix. The pooled antibiogram was also compared with the SNP community antibiogram and the hospital and health services regional data, which was sourced from Auctrix. The dark blue bars represent an overall comparison of all pathogen antibiotic pairs amongst the pooled and other antibiogram, and the orange bars represent the comparison of clinically relevant pathogen antibiotic pairs only. So basically the susceptibility data for the first-line recommended antibiotics. We can see that the percentage similarity was higher when our pooled antibiograms were compared with other available RAF data, but the comparisons with hospital data was mixed and no conclusions could be drawn from that analysis. So in summary, our systematic review suggested that the knowledge of local resistance patterns provided by antibiograms may improve antibiotic prescribing appropriateness. By extending the time period of data to 3 years, by pooling the geographical data, RAF antibiograms could be feasible. And by engaging private pathology providers to provide susceptibility data for RAFs, this would be of benefit going forward for any home that is wanting to have their own antibiograms to reflect local resistance patterns in their area. Just some references that I've used, and that's it. Thank you.
Thank you, Dipti, for that presentation. That was excellent. We've got a question from Ree. She is a vet by background, and she mentioned that she's quite surprised that the urinary E. coli had lower susceptibility to synergistic Bactrim than to trimethoprim alone, and whether you would be able to explain that result.
So I've just the word has just left me, but because this was a manual collection of pathology data, we could only report on what was provided to us on the pathology report. And pathology providers sometimes suppress the findings of data to second line, third line antibiotics. So this was something that could have sort of colored the actual true resistance patterns for those other antibiotics. It would have been good to get all the data, but we wouldn't have received all the data when we're just looking at the individual resident results. So that might have been what explained that.
Thank you. I'm going to ask you the same question I asked Stephanie about future directions and what the next steps are.
So future directions, really, I think my work provided some baseline information now for really further research into how can we actually make this, data available. Homes want this data. So when we talk to our residential aged care facilities, they were so keen on having this information. But it's not easy to get this information. And how can we engage with our pathology providers to provide this information? Right now, it's not mandatory for them to contribute their data to our ORA reports and, national databases. And can that be a mandatory thing? So we can have a more clear idea of resistance. Could it be postcode resistance? Could we sort of look at postcodes and say, okay, this is the resistance patterns? But there's more work where, to be done to get to that point. And I think the next steps would be finding that bridge on how can we liaise better.
Great. There's a question from Holly. She's wondering what method of data collection you used from the pathology report, and were you able to get any data or information on previous antibiotic treatments?
No. So this study was solely focused on the actual microbiology data collection. So the method really was finding all positive culture results that I could possibly get and collecting the data available on the individual residents' pathology, microbiological investigation. And we couldn't look at then which antibiotic. It was all de-identified. We didn't have that sort of work on who's used what antibiotic before, but we did try to adhere to that recommendation that first isolate per time period be used. So if somebody was on repeated antibiotics and had multiple culture results in the year, we would be only looking at the first result in that 12-month period. So I think that's why that recommendation is there.
Excellent. This is another question from me, but you've already alluded to this in your presentation. You mentioned that antibiograms can be very difficult and complex to interpret. With, I guess, the stakeholders and end users of this intended report, who would be responsible for interpreting these results? And what would they do with this information? You talked a bit about it in the decision support pathway already.
Yeah.
I don't think it's something that GPs can easily interpret.
Yes. And so that came out of our stakeholder analysis. And it was established that we would really need and that one of the recommendations, that's where that flow chart really came from. One of the recommendations was how can we easily use this information instead of looking at the table, which can be quite complex to interpret. And so the idea of the flowchart came from that stakeholder analysis. And really, we don't want the antibiogram to promote antibiotic use. We want it to be used in combination with the correct clinical criteria of infection, and then following all the steps, doing the MSU, for example, for a urinary tract infection, catheter, no catheter, signs and symptoms of infection, yes or no. And then the antibiogram really falls into that whole treatment plan. And I think the best way to articulate it all was through that sort of treatment algorithm. So it clearly kind of identifies. And that information then provided is based on the local resistance data. 71% of the most commonly identified pathogen are sensitive to trimethoprim. And so the prescriber is given that information. They can then make their decision based on the resident's previous antibiotic use and that sort of thing.
Great. Don't think there's any other questions. We might wrap up today's session. So once again, thank you both to Stephanie and Dipti for your excellent presentations. The presentation will be recorded and made available online. And just a reminder that next month's session will be on 18th of June, and it will be an allergy focus session. Thanks, everybody.
Thank you.
Thank you.